Hi, everyone. Thank you for joining today's MVP Development Kickoff webinar. We're going to give folks just another minute to get on the line before we get started. Hi, everyone. Thank you for joining today's MVP Development Kickoff webinar. During this session, CMS will provide an overview of MIPS Value Pathways, MVP's development for the 2023 performance year of the Quality Payment Program and beyond. CMS will take as many questions as time allows during the Q&A portion at the end of this presentation. Please note that we will not be monitoring the chat box during this presentation, so please make sure to send all of your questions through the Q&A. During this webinar, CMS subject matter experts will summarize new criteria for MVP development and review the MVP guiding principles. They will outline the process stakeholders should know for submitting an MVP candidate for consideration through the CMS standardized submission template. Now I will turn it over to Katie Moore, Health Insurance Specialist at CMS, to begin the presentation.
Great, thank you, Emily, and good afternoon, everyone. Thank you so much for joining us today, and good morning to folks that are joining us from the West Coast. Thank you again. And today we are so excited to be talking about our MVPs, so MIPS Value Pathways, and it's very exciting for us to be able to talk to you all specifically about the ones that we have finalized for 2023, and talk some more about development of new MVPs, and then definitely more about the maintenance process going forward and candidate submission template and more information there. So we have a number of our subject matter experts. Our entire MVP team is here to help answer questions as we can throughout the presentation. So again, as Emily stated, please use that Q&A function at the bottom instead of the chat. That would be really helpful so we can keep track of all the questions and get to as many as we can throughout the presentation while we're talking. And then we'll try and save as much time as possible at the end where we'll explain how to be able to raise your hand and ask a question live as well. So thank you so much again for joining today. And for folks that are new to this work and are wondering what in the world MVPs are, these are our MIPS, so merit-based incentive payment system, value pathways, and we'll get into a lot more details about what they specifically are for 2023 throughout this presentation. But generally, they are an aligned set of measures and activities that are really intended to improve how clinicians are able to participate in MIPS, which is part of the Quality Payment Program, and really make sure that it's meaningful participation for clinicians. You're not just, reporting on measures and different things that don't mean a lot to how you practice or your clinician, what type of clinician you are and what type of medicine you practice. So really want to make this program as meaningful as possible, and as always, keep the patients at the center of our work. So in the 2022 physician fee schedule final rule, we created 7 MVPs that we'll go into more detail about, along with some policies that support the implementation of these MVPs starting in performance year 2023. So we have some time before we start participating through MVPs. And we really hope that this time frame will give clinicians the time you need to understand the requirements associated with the MVPs and plan for any operational considerations that you might need to think through. And again, this MVPs won't be starting until 2023, so we definitely have a little bit time to get used to them. So we really look forward to continuing our collaboration efforts around MVP development for 2023 and the coming years beyond that. And we appreciate your support, everyone, in improving the quality payment program and helping us to do what's most important and keep your patients at the center of our work. The next slide, please. Great, thanks. So this is just a quick rundown of what we'll be discussing today. I'll turn it over in a few minutes to my colleague, Sophia Sugumar, who is our resident expert on all things MVP. So she will go through our 2022 MVP policy updates that we just finalized recently in the PFS final rule. We will go through some MVP candidate submission, the criteria for that. And when we say candidate, these would be new MVPs that are being submitted to CMS for consideration and review. So we'll go into more detail on our MVP candidate content and review process, as well as a really great resource that we have, our MVP development standardized template. So this is our includes everything you need to know about the MVP development process. So our colleague Deb Calder will be going through that in some more detail as well. And then we'll go through our MVP maintenance and help and support, and hopefully leave some more time at the end for questions. And with that, I will turn it over to Sophia Sugumar.
Thank you, Katie. Hi, everyone. My name is Sophia Sugumar, and I work primarily on the MIPS Value Pathways with a lot of our colleagues that are on the call today. So thank you all for joining us, and happy holidays. So to get us started, we'll kind of recap what we finalized in the 2022 PFS final rule that was just released last month. So if we can move to the next slide, please. Okay. So you may be familiar, if you have been following our MVP framework implementation. We had previously finalized the MVP framework, in which we've included guiding principles that would actually really structure how we move the program into a more meaningful and valuable manner for clinicians and patients. So with our guiding principles, they really kind of inform our work and what we would consider when we develop MVPs, when we develop policies for MIPS Value Pathways. They're essentially our foundation. And so you'll note that we have previously proposed and finalized these guiding principles in the 2021 rule. And we did actually make some updates to really reflect some of our policy updates for MVPs within this 2022 final rule. So those updates are noted in red. So our first guiding principle is that MIPS Value Pathways should consist of limited and connected complementary sets of measures and activities that are meaningful to the clinician. And this will reduce clinician burden, align scoring, and lead to sufficient and comparative data. We really want measures and activities within a MIPS Value Pathway to be complementary with one another and supporting whatever clinical topic is being measured. And that really speaks to kind of the comprehensiveness of care that is given for a given clinical episode. So we really are looking for those complementary relationships between the measures and activities that are included. So you can say that our MVPs for each clinical topic are a bit customized based off the clinical topic. We try to be cognizant of including the most appropriate cost measures, quality measures, and improvement activities to really balance out our foundational layer that we'll get to in a bit later. MVP should also include measures and activities that result in providing comparative performance feedback, performance data, which is valuable to patients and caregivers in evaluating clinician performances and making more informed decisions about the care they receive. And we've added through this final rule that MVPs will also enhance comparative performance data as they allow subgroup reporting, which allows for more comprehensive and meaningful data that's really directly attributed to that subgroup, which will reflect the services provided by members of a multi-specialty group. Currently, with multi-specialty reporting, you have large groups that are multidisciplinary, multi-specialty that don't necessarily report on metrics that are really attributable to all the specialists within that group. And so with subgroup reporting, we're trying to resolve for that and have more granular reporting by having subgroups form and allowing those subgroups to report on measures that are more meaningful to their practice and directly attributed to the clinical actions that they take on a daily basis. So really having that more meaningful data is more meaningful to the clinician in making improvements in the care they provide, but also to the patient and understanding how their clinicians and specialists actually do and how they perform and making better and more informed decisions about the care they receive. MVP should also include measures that are selected through our Meaningful Measures initiative that we have been promoting for the past 2 years. And whenever possible, the patient voice should be included within the MIPS Value Pathway to encourage performance improvements in high priority areas. So we continuously, as Katie mentioned several times, are keeping the patient in the center of our work. So to the extent we can include measures that reflect that, whether that be care coordination type measures, patient experience, patient survey measures like the CAPS for MIPS measure, we certainly do encourage the utilization of those measures in the MVPs to really make sure that the patient's voice is being heard. MVPs, and a long-term goal for MVPs is to reduce barriers to APM participation by including measures that are a part of APMs wherever feasible, and by linking cost and quality measurement. Lastly, as a new finalized guiding principle, we did finalize that MVPs should support the transition to digital quality measures. And so we have several measures in our MVPs and in our MIPS inventory that are digital, but working towards that ultimate transition of having a lower burden when it comes to reporting is a goal of the agency, and so that is a long-term vision we hope to achieve over the next few years. Next slide, please. With regards to the development criteria, we did previously in the 2021 rule establish several criteria on which stakeholders could use to then develop an MVP. And those are published in our QPP resource library. We have an MVP development subpage within there that has a list of this criteria and the template that we'll get to a bit later. So within this final rule, we did add a few criterion, and this really is to clarify, but then also align with some of the policy updates we did just make through the 2022 rule. So for the first few items, we are discussing the inclusion of outcome measures and high priority measures. And this is really to align with our requirement that for the quality performance category, a clinician must report 4 measures, one of which must be a high priority measure or an outcome measure or a high priority measure if an outcome is not available. So to the extent we have MVPs were created for a certain specialty, we should be looking to include outcome measures in there. And the outcome may also include intermediate outcome or patient-reported outcome measures per PMs. There are instances where we don't have outcome measures for all specialties, and we are aware of that. And so in those instances, we do want to make sure there are high priority measures included for each of those specialties that are involved in the MVP. I will note that there are certain MVPs where we have several specialties involved. If you have MVPs that really are shaped to mimic or emulate the team-based care model. And in those instances, we want to make sure there are sufficient measures for all the specialists involved in the given MVP to report. So we want to make sure they have an outcome measures available to them or high priority in the instance outcome is not available. In addition to that, there are within the MIPS inventory several outcome-based administrative claims measures that are in the MIPS inventory that may be relevant for certain specialists. And to the extent they can be included in an MVP and within the quality component of the MVP, they should be, because that helps to reduce reporting burden when we can calculate the measures. So we certainly encourage the utilization of those if they're available and applicable to be included in the MVP. We also previously finalized that QCDR measures could be included within MVPs. And so to be included in the MVP, we just clarified that the QCDR measure must be fully tested at the clinician level, and that we would need to receive that from the QCDR themselves, the testing data to show us that the measure has been fully tested at the clinician level by the end of the self-nomination period. And this will really then inform our decision as to whether or not that QCDR measure can be finalized within a given MVP. So you'll note that this last bullet here refers to that September 1st deadline for QCDRs, and that really aligns with the self-nomination close date, end date, which is September 1st. If for some reason we are unable to receive testing data that signifies a QCDR measure is fully tested at the clinician level by September 1st, unfortunately, that will indicate to us that we cannot finalize that QCDR measure within the MVP. We do not want to be in a situation where we finalize measures that are not fully tested, and then there be some downstream impacts to clinicians who then try to report on that measure, but then find that it's not actually implementable. So we would not be able to include that QCDR measure for the time being, but certainly if that QCDR is able to fully test the measure in a future year, we can reconsider the inclusion of that measure through notice and comment rulemaking. Next slide, please. So as Katie had discussed, MVPs will be available beginning with the 2023 performance year, and that's really to, being done with the delay to give clinicians and organizations and health IT vendors and other organizations time to prepare for a transition to MIPS Value Pathways. We have finalized 7 MVPs, and so those are available for voluntary reporting for the first few years. And we do encourage, to the extent, organizations and clinicians and groups have the time to early adopt MVPs that they should, just to orient yourselves and be more comfortable with that. That's certainly something we encourage all to do. For program year 2023, 24, and 25, we have finalized a term called MVP participants, which essentially groups all these clinician types that are sub-bulleted here into one term, and that when we use the term MVP participant, we mean that a given policy or a rule applies to all these clinician types. You'll note here that MVP participants under multi-specialty groups, there's a special asterisk there, and this to really signify that after 2026, beginning with 2026, multi-specialty groups will be required to form subgroups in order to report MVPs. So if a multi-specialty group in the first 3 years of MVPs, which is 23, 2024, and 2025, they have the option to continue to report as a multi-specialty group or choose to report as subgroups. But then beginning in 2026, if a multi-specialty group wants to report a MVP, they can only do so by reporting as a subgroup. Next slide, please. And we did finalize also with all the other MVP related policies an MVP registration process in which any MVP participant, which is a clinician or a group or APM entity or a subgroup, would need to register in order to report an MVP. And this really helps us for tracking purposes and also for purposes of understanding where we need to provide enhanced performance feedback, which we'll get to a bit later. So the registration period will begin on April 1st and end on November 30th within the applicable performance year to report an MVP. So the first registration period will begin April 1st, 2023 and end November 30th, 2023. To register, MVP participants must select which MVP they intend to report. Within the foundational layer, there will be 2 population health measures. They must select one of the 2 population health measures to be calculated on. And if there are any outcome-based and administrative claims-based measures within the quality component of the MVP that the participant intends to be scored on to count as one of the 4 measures or meet the outcome measure requirements, they must provide that indication as a part of the registration process. After the close of the registration period, an MVP participant won't be able to make any changes to their registration selections or report on any MVP they didn't register for, or report on more than one MVP. Next slide, please. For our third-party intermediaries that participate in the program, which are the QCDRs, qualified registries, health IT vendors, and the CAPS for MIPS survey vendors, there are implications to the MVP policies being finalized. So we did indicate through the rule that QCDRs, qualified registries, and health IT vendors would be required to support relevant MVPs beginning with the 2023 performance year. And that's really to get at that not all QCDRs or registries or health IT vendors support all specialties. We are aware that there are certain vendor types that only support a single specialty or perhaps a broader specialty and some subspecialties underneath that specialty, but not necessarily every single specialty that exists within the clinical universe. And so for that reason, we want QCDRs, registries, and health IT vendors to select MVPs that are clinically relevant to the clinicians they support and support those MVPs beginning with 2023. And with that, to also support subgroup reporting. So if a subgroup wishes to use a third-party intermediary to report an MVP, they have the capability to conduct that outreach and get that support from a third-party vendor to help their reporting to the MIPS program. In addition, the CAPS survey vendors will be required to support subgroup reporting specifically for the CAPS for MIPS survey measure beginning with 2023. So CAPS survey vendors are limited in what they support for our program. They only support the CAPS for MIPS measure. And so with that, we know that they wouldn't have the capability to necessarily support MIPS Value Pathways. So there are instances where we may have the CAPS for MIPS survey measure included in certain MVPs. And in those instances where a CAPS for MIPS measure is included, and for example, if a subgroup would like to report that CAPS for MIPS measure as one of their 4 quality measures, they should be able to use a CAPS survey vendor to then make that election and report that measure. So we have finalized that policy as well. Next slide, please. And here are the 7 MVPs we have finalized through this rulemaking cycle related to various clinical topics, as you may see here: rheumatology, stroke care and prevention, heart disease, chronic disease management, emergency medicine, lower extremity joint repair, and anesthesia. You'll note that the last 3 MVPs were finalized with modification. The emergency medicine and anesthesia MVP were finalized with the exception of 1 QCDR measure from each respective MVP where we did not receive testing data, while the lower extremity joint repair MVP was finalized, and I believe we finalized with the inclusion of an additional improvement activity based off of public comments. Next slide, please. And I'll just say, sorry, related to the previous slide, that if the details of each of the MVPs can be found within the final rule, the offices our publication of the final rule within the appendix of the rule. It includes each of the tables for the MVPs. So you'll get the details of each measure and activity that are included within those tables. So to touch upon the reporting requirements, the reporting requirements are for all participants, including subgroups. And so, as I mentioned before, for quality, and a participant would have to select 4 measures, one of which must be an outcome or a high priority measure if an outcome is not available. For improvement activities, and a participant will have to select either 2 medium weighted activities or 1 high weighted activity, or the PCMH improvement activity if it's available in the MVP. And for cost, the participants would be calculated on all of the cost measures that are included in the MVP, and they are calculated automatically using administrative claims-based data. So clinicians do not need to choose which cost measures to report. They'll just be calculated on whatever is included within the MIPS Value Pathway. The foundational layer of all MVPs are the same, so they are considered agnostic. The population health measures are not considered a separate performance category. They are a part of the quality performance category. Technically, they are quality measures. However, MVP participants will be calculated on the population health measures. They will be given the opportunity to select one population health measure to be calculated on. The calculated measure will then be added to the quality score. And the requirements for promoting interoperability are the same as which that is required under traditional MIPS. There are no changes to that under MVPs. So you will be required to report on the same standards that are expected of you under traditional MIPS under the MVPs here. Next slide, please. For scoring, there are many changes that we discussed in the 2022 final rule webinar related to quality scoring that are going to be in alignment with what we do under MIPS Value Pathways. So each measure will receive between 1 and 10 measure achievement points, minimum requirements, and data completeness requirements will apply. Our scoring flexibilities will be applied for measures with changes during the performance year. We will use the 4 highest scoring measures if an MVP participant reports on more than the required number of quality measures. A participant will receive 0 points for any required measure that is not reported. And if an outcome-based admin claims measure is available and selected by the participant at the time of registration to fulfill the outcome measure requirement, but for some reason the measure cannot be calculated, for example, the participant can't achieve or reach the desired case minimum threshold, then that would result in a 0 for that measure where you could not meet the requirements to then have the measure calculated, which is why, as you note in the box further down below, we do urge and encourage participants, if they're not sure if they can be calculated on a given administrative claims-based measure within the quality component, to report an extra outcomes measure, just because it would save you the benefit of, you would get a score versus just having a 0. So it's more of a safety if you're unsure whether you can meet the case minimums to meet the necessary thresholds to have that measure calculated for you. For cost, our scoring policies align with what's being done under traditional MIPS. The only caveat here is you're not being calculated on all the cost measures in the inventory. You're only being calculated on the cost measures included within the MVP that is selected by the participant. For improvement activities, the medium-weighted improvement activities will be assigned 20 points, while the high-weighted improvement activities will be assigned 40. Next slide, please. As I mentioned before, the population health measures are not their own performance category. They are considered a part of the quality performance category, and it will be the score of the population health measure will be included in the quality performance category score. We have some policies in traditional MIPS that are around administrative claims-based measure scoring, and these scoring policies will be applied here in MIPS Value Pathways. So the administrative claims-based measures will be excluded from scoring if the measure doesn't have a benchmark or achieve case minimum. So if the participant can't achieve the case minimum for whatever reason, they don't have enough cases, in that instance, the measure will be excluded from the score. Population health measures are not considered their own new performance category. The only exception to this rule related to the measure being excluded if the case minimum cannot be reached is if the subgroup, who is then part of their affiliate group, if the subgroup cannot be scored on the population health measure, but their group can, then the subgroup will receive the group score. For promoting interoperability, measures are scored in alignment with traditional MIPS scoring policies. The only caveat and nuance here is that subgroups will be able to submit PI performance category data of their affiliated groups. So PI is always going to be calculated at the group level for subgroups at this moment. Next slide, please. With regards to final scoring, MVP scoring policies for determining the final score will generally align with traditional MIPS performance category weights. Reweighting policies will also align with what's being done under traditional MIPS. There's only one exception to that, which is the quality performance category, which won't be reweighted if we can't calculate a score for MIPS eligible clinicians, because there isn't at least one quality measure applicable or available to the clinician. And MVP participants will receive a final score that's based on their MVP reporting, unless a higher score can be attributed to the MIPS eligible clinicians from another reporting option or participation option. So just what that means is that if an MVP participant reports an MVP, but then also decides to report traditional MIPS and meet all the traditional MIPS requirements, both scores will be calculated separately, and then we would compare the two and take the higher of to count as the final score. Next slide, please. All right, so now we're going to get a little bit more into the weeds of the MVP candidate submission criteria and the development process and eventually the maintenance process. Next slide, please. Okay, so to provide an overview, and really the main reason why we're having the webinar today is provide an overview and a refresher for some about the MVP candidate process and what happens during the process when you submit a candidate to us, and what will happen with the future process of setting up a maintenance process that we've just recently finalized. So when we refer to a candidate, it means it's not necessarily considered officially an MVP. It's a candidate that can be submitted for CMS consideration for us to then officially determine whether or not it can move forward as a feasible MVP. So we will host an annual public-facing webinar to inform stakeholders of MVP development and maintenance criteria, timeline, and process, which is what you're attending today. And then invite interested stakeholders to submit MVP candidates for our consideration and potential implementation through future rulemaking. And I just want to note, this is a separate call from we have various calls that happen within the MIPS program for call for quality measures, call for improvement activities, call for cost measures. There's even a solicitation for specialty set recommendations. This is separate from all of that. And I do want to note that, submitting a candidate to us does not necessarily mean it's going to be implemented right away, or it does not necessarily mean that it will be accepted. So there are several caveats we'll get to later about what we look for in terms of an MVP. So the candidate MVP submissions must be submitted no later than, sorry, I think that's a bit of a typo. Candidate MVP submissions will be accepted on a rolling basis, and I think that needs to be updated on the slide presentation here. And we will then take the time to review those candidate MVP submissions that are received and then determine, one, whether they're feasible, looking at the attributions of the measures, and then also determining the timing of when this MVP, a given MVP candidate, is ready to move forward through notice and comment rulemaking. So, if, for example, we receive MVPs that are reviewed by, February 1st, and there is potential for it to then move forward through the upcoming rulemaking cycle for 2023, depending on how engagement with the stakeholder who submitted the MVP goes, how the measures meet our criteria, whether we have identified a potential cost measure and confirm the cost measure is applicable and relevant to the MVP and the attribution is appropriate. So there are several nuances that are caveats. There's no necessarily a guarantee that an MVP will move forward if submitted by the early part of the year. We will also vet to make sure for all measures that the coding validates the inclusion of the given measure within the MVP. We have whether or not all potential specialty specific quality or cost measures were considered with the most appropriate included. An MVP candidate must include a viable cost measure in order to be considered feasible. So we will not be able to move forward with any MVPs that don't include cost measures. If for some reason you include for example, one of the global cost measures, and we've come to identify that the global cost measure does not include a given specialty that you've tried to capture within your MVP, that also may be a trigger for us to indicate to you or inform that the MVP is not feasible at this time. Next slide, please. With regards to our review process, once a candidate is submitted to us, we will then take it back and with our team review all the individual measures and activities that are included to one, confirm the appropriateness of their inclusion, the coding and the attribution of the given measure to the clinician type trying to be measured within this MVP. We will also look to see if there are additional measures or activities that should be considered for inclusion. We may reach out to the stakeholder who submitted the MVP if any questions arise during the process. We may reach out to meet with you to discuss any of our feedback. And submitting an MVP candidate at DURA does not guarantee that it will be proposed for future rulemaking cycles, or does not necessarily guarantee that we have identified the MVP to be feasible. There have been certain circumstances where they have not been feasible, and there might be limiting factors related to availability of measures and whatnot, or the availability of an existing MVP where we might ask for there to be collaboration amongst stakeholders. So there are several nuances we will track to. We are not trying to pursue having several MVPs that address a duplicative topic. We want to make sure we're very cognizant of having MVPs that are unique from one another and do not necessarily create duplication and confusion. And so, once an MVP is received and we've reviewed it and then have had some iterative discussions with whichever stakeholders have submitted the MVP, we will then take the feedback into consideration, but then from that point onward, any consideration of determining when and whether MVP will move forward, MVP candidate will move forward through notice and comment rulemaking will be entirely on CMS to decide. We will not be able to communicate ahead of the rulemaking process to a given stakeholder that your MVP has been selected and it's ready and it's definitively being proposed through notice and comment rulemaking. We cannot jump ahead of the rule. So all those, the communication of that will be our rule to indicate to you as the stakeholder who submitted the candidate that this MVP is moving forward. MVP should be focused on a given specialty, condition, or episode of care. In our rule, we also discussed the inclusion of MVPs that reflect the team-based care model, where you may have several specialties involved, and we highly encourage, specialties and stakeholders to consider MVP development in that way to have more cohesive and comprehensive consideration of the care provided to a given patient. And that might include clinicians that are involved during the episode of care. It might involve clinicians such as, if you're having a surgical episode, and sure, we're including your anesthesiologist or your CRNAs, and perhaps if it's something that's related to joint repair, something that also considers the use of post-surgery, therapy that patients may need post-surgery, so physical therapy, occupational therapy. So considerations of having more cohesive perspectives on the clinical episode is something we're encouraging our stakeholders to take on. And so once you, if our our measures and activities for MVP development that are currently in MIPS are available for your review on our QPP resource library. I do want to say that we've heard from stakeholders about questioning whether or not we would allow for the inclusion of measures that are not currently in MIPS. It's not something, it's something we are open to. It's just that those measures would need to follow our typical processes. So then call for measures process for MIPS quality measures, or be submitted as a QCDR measure, and then therefore be a fully tested QCDR measure in order to be considered for inclusion in MVP. We could not just directly take a measure outside of MIPS and then plop it right into an MVP without going through all those formal processes. And so with that, considering all the data, all requirements that we have, once a given stakeholder has an MVP related to a given topic that's in their eyes ready for our review, they can submit it to this inbox that's listed here, and that will kind of trigger our evaluation process to then review, and then once we complete our review, conduct some outreach. Next slide, please. Okay, so we're going to now discuss the content and review process for the MVP candidates. Next slide. For the guidance, and this is something I think we would like you all to keep in mind as you come up with your MVP candidate submissions, that the MVP should include quality and cost measures and improvement activities that are currently available in MIPS to the extent possible. And you can review our library for the most recent list of measures and activities. Measures and activities that are not currently in MIPS have to go through our processes, so our pre-rulemaking processes, in order to be considered for inclusion. If you are an organization that has a QCDR and you want to put a measure in as a QCDR measure, you have to follow those QCDR measure processes to ensure that a measure is approved as a QCDR measure before it's considered for inclusion in an MVP. Next slide, please. For quality measures specifically, the current inventory of quality measures and QCDR measures include both cross-cutting measures and specialty-specific measures. And so here are the links. They're all available through our QPP resource library to these various lists that may be helpful for you to preview, and then also consider as you do your environmental scan when you're trying to think of an MVP topic. To see, I would encourage an environmental scan of our existing resources before you begin any type of MVP development. Next slide, please. And improvement activities. Improvement activities are broader in application and cover a wider range of clinician types and health conditions. And those that best drive the quality of care addressed in the MVP topic should be prioritized and included. Improvement activities should complement or supplement the quality action of measures in the MVPs rather than duplicate them. So we are, again, as I mentioned before, looking for complementary measures and activities to work together to kind of message that episode of care and kind of really reflect that. So in addition, MVP should seek to identify and incorporate opportunities to promote diversity, equity, and inclusion by selecting health equity focused improvement activities. There are currently 23 health equity focused improvement activities in the current inventory for you all to review. We certainly, as a part of our review process, if we see that they're not included, we'll suggest the inclusion of certain ones we feel appropriate. But we do encourage you all to take that on proactively and see if you can try to include some IAs related to equity and diversity and inclusion as a part of your MVP development itself. We also, just as a side note here, there is a call for improvement activities process, and so the new improvement activities may be submitted using the 2021 call for measures and activities process, which is outlined in our QPP resource library for those that are interested in creating new improvement activities. Next slide, please. For cost measures, the current inventory of cost measures includes population-based cost measures and episode-based cost measures. The episode-based cost measures represent various types of care, episode and patient condition groups. There are procedural episode-based cost measures that apply to clinicians, such as orthopedic surgeons, that perform procedures of defined purpose or type. There are acute episode-based cost measures that cover clinicians, such as hospitalists, who provide care for specific acute conditions. And there are chronic condition episode-based cost measures that account for the ongoing management of a disease or condition. There are also two broader types of measures that are population-based cost measures that assess episodes of care built around a patient's admission to an inpatient hospital, which is the Medicare spending per beneficiary, or what we call the MSPB clinician measure, and the overall cost of care reflecting an ongoing primary care type relationship. So this is our total per capita cost, or our TPCC measure, that are also available for inclusion. I will say to the extent we can include as a part of your MVP development, if there is a relevant episode-based cost measure available, we strongly encourage you to include those in your MVP. That will be something we also look at from our end once we receive your submission. There have been instances where the global or the broader cost measures, which are the MSTB and TPCC, have been included. And we will say, there have been instances where we could not move forward with an MVP because even though they are broader, there are some attribution considerations that we have to look at. So there may be some instances where I think there are assumptions that all specialties would be perhaps attributed to this measure, but they're not. So we just want to caveat that if you are thinking to include those two broader measures, take a look at that attribution to confirm that those measures are appropriate for inclusion when you don't have an episode-based measure. Something we will certainly check on our side as we validate, but we want to make sure. I think sometimes it comes off as a surprise when we're not able to use those measures. So just want to flag that. Next slide, please. For the cost measures, the CMS measure development contractor continues to develop new episode-based cost measures through a systematic development process, which involves extensive stakeholder engagement and opportunities to engage, I guess. And information about these measures is available on the MACRA feedback page for your review. We have also finalized a cost measure development process by stakeholders to account for externally developed cost measures. So we are beginning to establish a call for cost measures process where stakeholders interested in developing their own cost measures can submit them for CMS consideration for use in the MIPS program. And this would be kind of similar to the call for quality measures process that currently exists. This process will beginning with the 2022 program year. Measures submitted will be available for earliest adoption into the MIPS program beginning with the 2024 performance period. And this really accounts for the formal processes that the measure must undergo, including the call for measures, the MUC-MAP process, which is the measures under consideration, and the measures application partnership, which is a consensus-based entity review, which precedes rulemaking. So it's a bit of a longer time, but it helps to ensure the measures have that support before they move forward. The MIPS cost measures are calculated for clinicians and clinicians groups based off of administrative claims-based data. So information about the cost measures can be found within the resource library for those interested. Next slide, please. Additional considerations for our review process. So we have included within our, and you may see this in our MVP development template, some additional considerations posed as questions for you to consider as you develop your MVP candidate submission. And they cross several performance categories. So within quality, we want to make sure there's considerations for the quality measures. Do they meet the existing quality measure inclusion criteria? Does the measure, for example, are you cognizant that the measure has a performance gap? We're trying to avoid including high performing or topped out process measures that we have limited value in the program. That may be ones that may be considered in the near future for removal. We have signaled our desire to move away from those types of measures over the past few years. So being cognizant of that as you're identifying measures, how the quality measure denominator's been evaluated to ensure that the applicability of the measure and activity within the MVP. So measure denominators really speak to the quality measures and the cost measures, but the denominator aspect of it is really looking to see who can actually be included. When you think of the broader picture of your MVP, does it actually fit? And be mindful of that, because there are certain instances where within measured denominators you have certain specialties or clinician types that may be excluded, and so you want to be mindful of that as you're selecting measures. For improvement activities, what role does improvement activity play in driving quality care and improving value within the MVP? And we look for rationales to really understand your perspective of why these improvement activities were selected. And we're really looking for the improvement activity to supplement or complement the quality action that's occurring within the MVP rather than duplicate it. I don't know that we necessarily see value in duplication. We want to see essentially, a variety of actions that occur that really complement one another, that really support the overall the quality function that's occurring within the MVP. So that's something we would like you to keep in mind as well. For the cost measures, what role does the cost measures play in driving quality of care and improving value as well? We also want you to include a rationale for our understanding of your perspective, and how does the selected cost measure relate to the other measures and activities within the other performance categories? So again, building on these cohesive relationships between the measures and activities, understanding your perspective of how the measures and activities work with one another to provide this overall vision of what we're trying to achieve within the MIPS Value Pathway is something we want to make sure we understand. You can find the full list of additional considerations kind of posed as questions like this within our development template, which is posted on the QPP resource library. Next slide, please. Okay, and so with this, I'm going to turn it over to my colleague Deb to go over our MVP development standardization template. Thank you.
Thank you, Sophia. Next slide, please. All right, we are encouraging stakeholders to submit MVP candidates for consideration for potential future implementation by leveraging the MVP development standardization template. The template is currently available, as Sophia said, in the QPP resource library within the regulatory resource section, specifically the 2022 QPP final rule resources zip file at this time. In order for an MVP candidate to be considered feasible, it must include a sufficient number of quality and cost measures and improvement activities. The foundational layer of all MVPs includes the entire set of promoting interoperability measures, as well as the 2 population health measures, the hospital-wide 30-day all-cause unplanned readmission rate for MIPS groups, as well as the clinician and clinician group risk standardized hospital admission rates for patients with multiple chronic conditions. In this template, submitters will not need to add the promoting interoperability measures or the population health measures. Since these measures are required to be included in all MVP candidates and cannot be changed, you will see that they have been included in tables 2B and 2C for your convenience. Next slide, please. The MVP development standardization template is broken down into a couple of tables. Please note that you must complete and submit both tables 1 and table 2A of the template for each intended MVP candidate. If both tables are not complete, CMS will be unable to consider the submission. Table 1 is for interested parties to provide high-level MVP descriptive information, including the MVP name, contact information, and intent of measurement, measure and activity linkages, appropriateness, comprehensibility, and incorporation of the patient voice. A checklist is included in Table 1 to assist stakeholders in identifying and providing the type of information that would be useful for CMS consideration of the submission. Next slide, please. So slide 27 is a continuation of what you found, what was on slide 26 within Table 1 of the MVP development standardization template on the qpp.cms.gov. The more comprehensive the information provided by interested stakeholders, the more likely the team will be able to provide timely and efficient feedback to your submission. Next slide, please. Please refer to the appendix of the template, which you'll find located on pages 14 and 15 on the online version for further guidance regarding measure and activity selection. As a reminder, CMS is not prescriptive regarding the number of measures and activities that may be included in an MVP. Therefore, when completing Table 2A, the number of rows included should reflect the number of measures and activities that are necessary to describe the MVP candidate submission. So you are able to add or remove rows as needed to this part of the template. The foundational layer of measures are included, as I indicated earlier, below in Tables 2B and 2C, and are pre-filled for each MVP candidate submission and should not be changed. Next slide, please. So for this particular slide, this is Table 2B, and this is the population health measures that, again, you'll find are pre-filled within the template. Next slide, please. And then slide 30 is just the first slide to Table 2C, which is the promoting interoperability measures that are pre-filled for each of the MVPs when you submit a candidate. Next slide, please. And I will hand it back to Sophia to go over the MVP maintenance. Thank you.
Thank you, Deb. Next slide, please. Okay, so within this 2022 final rule, we did finalize an MVP maintenance process. And this is really to speak to our established MVPs that we have perhaps previously finalized through rulemaking that are already implemented, and how we would maintain those over, the next few years. So for example, we have just finalized 7 MVPs that we just discussed. And so we want to be mindful that within our MVPs, there is potential for changes. Certainly, we don't want to be making unnecessary changes, but as you're all aware, with individual measures, there's annual measure maintenance. And so with measure maintenance, there may be certain coding changes or clinical guideline changes that we need to be cognizant of as we are making measure updates. And that also has downstream impacts to the MIPS value pathway. So we want to make sure any updates that are made within the measures are carried through to the MIPS value pathway. And if for some reason we need to reevaluate or reassess the inclusion of a measure based off of any updates that are made or perhaps are not made when they should be made, we will use the maintenance process to make those considerations. So the part of the maintenance process, it won't be just CMS making the changes independently on our own. There is a potential to consider. We have established a process for us to consider stakeholder recommendations to implemented MVPs of how they should be changed to either perhaps better them for future consideration. So we have finalized a process that will be available beginning for the MVPs beginning with the 2023 year performance year. This process for MVP maintenance is considered to be separate, though, from the new MVP candidate submission process. So you wouldn't have to fill out that entire template just to submit to us any changes you think should be made to an established MVP, that how we had finalized through rulemaking previously. Under this process, beginning in January of the year prior to the performance period, stakeholders will be able to submit their recommendations for revisions to established MVPs. We will accept input on a rolling basis, and all interested parties are invited to submit recommendations for potential changes to established MVPs. And the feedback is not limited to just those that had originally submitted the MVP for our consideration. There's also, is meant to be a broader solicitation for feedback. So based off of your review, or if there's any feedback you'd like us to consider for future changes, whether that be add measures or remove measures, or any other considerations you feel that are important, that we're happy to receive that feedback on a rolling basis. There's no formal template. We have similarly set it up in our manner similar to our specialty set, call for specialty set process. So feedback can be written and emailed to us in a letter form to kind of indicate where you feel changes should be made, and rationales as to why would be helpful as well. We will review those on a rolling basis as they're received, and the timing of whether or not we can make changes will be dependent on the timing of when we receive the changes versus when rulemaking occurs. We will not be able to communicate ahead of the rulemaking cycle and confirm that a given change will be made or that we won't make a change Essentially, it's you submitting comments to us for us to consider. We will then review the feasibility of making the change and then determine whether or not the change should be made and the timing of when that change should be made. And it will coincide with our rulemaking cycle. Next slide, please. I did touch upon the first item, so we will ultimately be the ones that decide whether an update should be made and whether when that update should be made, but we won't be able to communicate ahead of the rulemaking cycle that a given change is going to be made definitively to an MVP or not. Additional logistical information such as where to submit recommendations and any other detail that may be helpful in terms of guidance will be provided through the QPP Resource Library and listserv messaging prior to the opening of the solicitation process. So we are tracking to the need for that and are looking to provide more guidance to you all so you can make the most of that process. Any changes to MVPs will be addressed through notice and comment rulemaking and before, to be considered and implemented. If changes are made to existing individual measures and activities within the MVP, they would be made under traditional MIPS, those changes. They would follow those typical processes under the performance category requirements, policies and criteria to make those changes, and those changes would carry through to the MVP. So there would not be an instance where we would have, for example, last year's version of an improvement activity, which has been updated in this rulemaking cycle, but in the traditional MIPS space and not in the MVP space. The updates would always carry through into the MVP program. We are not keeping separate versions of the measures and activities for ourselves within the MVP space, just to be clear. Next slide, please. Okay, next slide. I think we just want to just touch upon some resources that may be helpful. We have previously, maybe I want to say a few weeks ago, had our QPP 2022 QPP final rule webinar. So there are resources available. I think the webinar, the slide deck and recording are also available in the webinar library that you might find helpful when you want to kind of learn more about the general updates in MIPS and how they carry over within the MIPS MVP program. That might be helpful to listen to. There's also more information available on our QPP website related to MVP candidate submission specifically. That link directly will take you to that subset of the website. You can also access it from our general QPP website as well, and hopefully that will help. Next slide, please. We do have technical assistance resources available. You'll note that we have resources for our small and solo practices, and we have technical support that's available to all eligible clinicians. You can leverage the information here to then take advantage of those technical assistance resources to the extent they are feasible. Just one flag here, SIRS assistance will end on February 15th, 2022. So we do encourage small practices to take advantage of the initiative within the remaining time that's left. Thank you. Next slide, please. All right, so I think we're now ready for the Q&A part of the presentation. So I'll turn it back over to the Ketchum team to get us started.
Thanks, Sophia. We're now going to start on the Q&A portion of the webinar. You can ask questions via the Q&A box or through the webinar audio. To ask a question through the webinar audio, please raise your hand and we will unmute your line so that you can speak. To submit a question anonymously through the Q&A chat box, please click Send Anonymously. Otherwise, all attendees will be able to view your question. So we can go ahead and get started. It looks like we have one person on the line with their hand raised, so I can go ahead and call on you for your question, Carol Saavedra. And you will have to unmute your line so that you can speak. Okay, it looks like Carol may not be on the line at the moment, but if you do want to ask that question, please raise your hand again. So we have a couple of questions that have come in through the Q&A box. The first one is, will each MVP have to have their own tax ID number? Sophia, do you have a response to that question?
Sure. So each MVP will be assigned an identifier. It's not a tax ID number, but it's an identifier that will help us from the submission standpoint distinguish an MVP submission from a traditional MIPS submission. So there will be a unique identifier assigned to each MVP. With regards to tax ID number, I don't think that relates to the MVP itself. That might have more so to do with whether a group decides to submit as a TIN versus a subgroup. If a subgroup submits on MVP, we certainly will need the information related to what TIN they are derived from, and a list of those clinician names that are a part of that subgroup, as well as a subgroup name that the subgroup has come up with. And we would need that information at the time of registration to really kind of just establish that this group of clinicians from this TIN is forming their own subgroup to then submit on whatever MVP, X MVP. And so that would really occur during the registration process.
Great, thank you so much. We've had a couple other questions come in. So our next question from the Q&A box is, when it said that health IT vendors must support MVPs by 2023, does that mean they need to support all quality measures within an MVP group, even if a measure is a QCDR or QR measure?
So the only exception generally third-party intermediaries, if you're supporting an MVP, you'll be expected to support all the measures and activities within the MVP. The only exception to that is if there are QCDR measures included, qualified registries and health IT vendors cannot report on QCDR measures at this point. Our policy does not allow for it. So they'd be expected to support all the other measures that are included in the MVP, which will likely be the ECQM collection type, or the CQM, which is the MIPS clinical quality measure collection type. And so supporting the reporting of all of those. They can't just select 4 measures within the MVP and only support those 4. They have to support the entire collection to the extent possible. A QCDR, if they report an MVP and the MVP has QCDR measures that are not their own, they should follow the appropriate steps to get those permissions before offering those QCDR measures as a part of their selection. We would expect that they follow the typical processes, and that would be validated at the time of self-nomination.
Great, thank you so much for that response. We've had another question come in through the Q&A box. Are MVPs going to replace MIPS?
We did signal in the rule, this past 2022 final rule, that we do see a future state where MIPS Value Pathways will eventually replace traditional MIPS. It's not something we've definitively finalized through the rule that we would end traditional MIPS by X year, but we do see a future state where that will eventually happen. Ideally, it would coincide with the timing of when we have enough MVPs available for all specialties that participate in the program.
Great, thank you. And we have another question. This attendee asked, am I correct in my interpretation that in order for a vendor to indicate they are supporting an MVP measure set, they must support all measures within that MVP measure set, not simply a subset? For example, with the stroke care MVP, is it a vendor's responsibility to support all 8 quality measures, either ECQMs or CQMs? Or could a vendor say that we are going to support 4 of the ECQM or CQMs within an MVP measure set for submission, but not support all 8 quality measures?
No, they'd have to support all the measures and activities that they can support under that MIPS Value Pathway. So when I say can support, I'm saying by collection type. They should, qualified registries, for example, and health IT vendors should be able to report on ECQMs and CQMs. So they cannot select 4 of the 8 measures and only support those 4. They have to support all 8. Essentially, with the MIPS Value Pathways, the choice of deciding which measures to report on are left to the clinician to decide, not the third-party intermediary. So the third-party intermediary will be expected to support all the choices, with the exception for the QCDR measures if they're not a QCDR. And the clinician should be able to tell the third-party intermediary which of the 4 measures they intend to report for their MVP quality reporting requirements.
Great, thank you so much, Sophia, for that response. We do have a few other questions coming in through our Q&A box. So the next question is, when reporting both MVPs and traditional MIPS, will the higher of the 2 scores be selected during just the optional years of reporting MVPs, or also once MVPs are mandatory?
Well, good question. I think MVP reporting being mandatory is not something we directly address through rulemaking, because I think what we've said in the rule is we don't anticipate it being mandatory until we sunset traditional MIPS. So that being mandatory, in a sense, it's the only option available. So I think the scoring hierarchy between traditional MIPS and MVPs will continue to exist until we get to a point where we no longer have that traditional MIPS available, where you can't do the compare of the two scores to then determine the final score. But again, that is something that is a future state policy that we are currently working through to see how we can best address. But for the time being, those scoring hierarchy will consider both your score in traditional MIPS and MVPs.
Great, thanks so much. Our next question from an attendee asked, it did not look like MVPs currently support gastroenterology specialties. Can you confirm that? And if so, can they continue to report via MIPS?
Yeah, sure. So we don't have any gastroenterology related MVPs just as of yet. I will note that that is something we're looking to work on. So for the time being, reporting on traditional MIPS is perfectly fine. That just generally for those that are reporting in traditional MIPS now, if you don't see an MVP available to you, I would say continue reporting traditional MIPS, and then once one becomes available, we would encourage you to dip your toe in and slowly try to, get oriented to reporting MVPs, so that you're not left in a situation where in the future state, if we decide to ultimately sunset traditional MIPS, that you're, rushing to learn what MVPs are at the last minute. So certainly encourage those that have the MVPs available to them, that are relevant to them, to orient themselves and, transition over to MVP reporting as soon as they can. But in the meantime, for those that don't have MVPs available, you would continue to report traditional MIPS as you have been doing. And I just want to note with that, because it's been brought up and I forgot to touch upon it earlier, we are working on a list of MVP needs and priorities, so really a development priorities list, and we will publish that. That's something we want our stakeholders to be aware of. So as you're working on MVP development, it's something you can just be mindful of if you're working on a topic that it falls within that priorities list, and is helpful hopefully as you work through your development processes. So that is something that's forthcoming. I just want to flag that. Thank you.
Oh, great, thank you. Our next question is, when do you expect to have more information on the multi-specialty subgroup requirements? For example, what are the subgroup options? Do we create our own subgroups from the appropriate traditional MIPS measures?
Yep, we are looking to address, so subgroup reporting will be available beginning in 2023. There were certain aspects of subgroup composition that we did not directly address through this final rule. We sought comment on, for example, whether a subgroup should be made up of a single specialty, or should we allow for multiple specialties to be involved. That is something we plan to address through future rulemaking before 2023 hits, potentially through the next year's rulemaking, and offering that guidance. So we do anticipate the need to provide more technical guidance on subgroup reporting and forming subgroups. So that is also something we're tracking to provide more information on in the near future. So thank you.
Oh, great, thank you. Our next question is, can you please review again how reporting both MVPs and traditional MIPS will impact scores? Can you do both, or do you have to choose one or the other? We have a large TIN that has both family medicine and specialties, so we are unsure how to proceed.
Sure. So for the first 2 years of MVPs, which would be 2023, 2024, and 2025, and I'm just going to use your group as the example because you said you're a large 10 with family practitioners and also specialties. So as a multi-specialty group, you have the choice for the first few years of reporting as a multi-specialty group, or you can have your your various specialties form subgroups to report. You can, if you want to report an MVP, you can choose one of those two reporting options. You can also report traditional MIPS. So for those clinicians within your 10 that do not have an MVP that is relevant to them, they can continue to report traditional MIPS at the group level, while the others choose to report a MIPS value pathway that is available to them and relevant. What would happen is those that report an MVP would report that MVP either leveraging the multi-specialty group pathway, or they can also form a subgroup to report that MVP. If they choose the multi-specialty group and choose not to form a subgroup just as of yet and report one MVP, and then the rest of your clinicians in your group decide to continue to report traditional MIPS because they don't have an MVP available to them, what will happen is your scores for your reporting for traditional MIPS will be calculated and scored, and then we will separately score your MVP submission. We'll compare the two and see what is the higher of the two scores, and that will ultimately count as your as your final score. If your clinicians in your large 10 decide to form a subgroup and report on an MVP, they will just they will also get their score from their subgroup. But then if your 10 decides to report traditional MIPS as well, we'll do that comparison to see where you've done better. Is the subgroup score higher, or is the 10's group score in traditional MIPS higher? And then they will get the better of, the subgroup will get the better of the two scores. So they might get that 10 score for traditional MIPS if the group has holistically done better in traditional MIPS than they've done in the subgroup, done as a subgroup for reporting an MVP. So the scoring hierarchy explains all this, and I think there might be a helpful table within the rule, within the scoring hierarchy section within MVP that might be helpful there.
Great, thank you. So our next question is, if we have hospitalists in our group, where do they fall into MIPS and/or MVPs?
So I think hospitalists will consider the level or the setting of care provided. So I think part of it is looking at the MIPS value pathway to see if the measures within within the MIPS value pathway are relevant, clinically relevant, and looking at the coding to see that they involve the setting. So in this case, a hospital setting that would allow for that reporting. If they do, then certainly that MVP is available for reporting by the hospitalist. If for some reason the coding does not allow for a hospital setting to be reporting a given measure, for the time being, you would continue to report traditional MIPS. I think certainly hospitalist involvement in traditional MIPS, or MIPS generally, is something we are tracking to. So if it's not something we have already addressed through our existing MVPs, you can be sure that it is something we intend to have an MVP that's relevant and applicable to hospitalists in the near future.
Great, thank you. So next up, we've got a couple of questions about subgroups. The first question is they would just like to clarify the definition of a subgroup. And then the follow-up question is the expectation of a subgroup to create another TIN?
Can we go back is there a slide on the subgroup definition? I don't know that we included that.
I don't believe so.
Okay. I don't have the exact subgroup definition on the top of my head, but it is included within our 2022 final rule webinar materials. There's a slide specifically on subgroups and the definition of a subgroup, and it breaks down the eligibility and also whether it's voluntary versus mandatory, with the years and things like that. That might be helpful. If you refer to the webinar link that was previously shared, you can look at that webinar presentation to find that table, and that will provide you with the detail. And sorry, what was the last part of that question, Emily?
The second part of the question is they were wondering if the expectation of a subgroup is to create another TIN.
Oh, no. So our SMEs that are on the call, please interrupt me if I misstate anything. But the intention is not to create a separate TIN. Essentially, all subgroups are going to derive from a TIN or a parent group. And so we will associate, if you register as a subgroup, we will associate your subgroup registration back to your TIN, so we know where this subgroup is derived from. But the intention is not for you to create your own subgroup and then have your own TIN. That's not our case. We're just trying to allow for that subgroup, that group to then, in instances where they can allow for subgroup reporting where it's relevant and they have MVPs that are clinically relevant to certain specialists, give them the opportunity to then report independently of the group, and then get more meaningful results from that reporting, and a score that actually reflects their performance. But in no way are we asking them to create their own TIN.
Great, thank you. We had another question through the chat box that asked, how do ACOs participate in MVPs?
Well, they would have to follow our MIPS eligibility criteria in order to be considered MIPS eligible. And essentially, we would use our MIPS eligible criteria to then, determine MVP of eligibility. MVP is just a track under MIPS. So if you're considered MIPS eligible, then if you don't have an MVP available to you now, there will be a future state where an MVP can be available. I don't know if I could provide any other detail beyond that, but it's a bit more so dependent. Your eligibility or your applicability to participate in MVPs is really going to be dependent on whether you're considered MIPS eligible.
Great, thank you. And I think we probably have time for one or two more questions. So this next question is, how many MVPs are we anticipating to potentially be implemented for program year 2023? The current set of 7 is quite low for large multi-specialty groups. Do we expect the bulk of MVPs to be developed for program year 2023, or is it more likely they will come in program years 2024 and beyond?
Well, we are anticipating, we finalize an introductory set of MVPs. We anticipate that inventory will grow over time. It's not going to all happen by 2023, the 2023 rule writing year. It's going to happen over time over the next few years, but we anticipate every year adding a handful of MVPs a year. I can't give you an exact number or say definitively we'll have, X number of MVPs by 2025. It's difficult to say. There are a lot of caveats to consider, especially when it comes to availability of measures and making sure we have relevant measures and activities across all the performance categories. So there are some dependencies that will then contribute to whether the timing of when we will have enough MVPs available, but it is something we are tracking internally over time, and we do plan to continue to propose MVPs for the next few years to get us there.
Great, thank you. And I think this will probably be our last question. They asked if we have several specialists under a TIN we need to report for, and there are MVPs for some but not for others. Can we report traditional MIPS for the group overall, plus report the MVPs for the specialties that have them?
Yep, you can definitely do that. You would leverage, so when you report the MVPs, you can form subgroups to report those MVPs. So you can form smaller subsets of clinicians that are directly attributable to that given MVP. If you have some specialists that are only involved and not everyone within your group, they can form their own subgroup and therefore they can report on that MVP, while everyone else that remains in your group continues to report traditional MIPS and will be scored accordingly.
Great, thank you so much. And that will conclude the Q&A portion of this webinar. And now we will turn it back over to Sophia Sugumar to conclude the call.
Thanks, Emily. So thank you all for attending today. Really appreciate the time you all took to be here. Hopefully we answered some of your questions. Hoping the MVP development process and maintenance process is clear. Should you have any questions, please feel free to reach out to us at the QPP Service Center to really make sure we answer your questions. And we look forward to any future MVP submissions you may have, candidate submissions, and working with you all in the future. So happy holidays, everyone, and thank you again. Have a good day.